You're listening to Working in Oncology, a podcast and video show that spotlights oncology practice staff and industry influencers who work behind the scenes to shape the future of oncology. The more knowledge the oncology community shares with each other, the more we all grow. Let's get into the show.
Welcome to Working in Oncology. I'm your co-host, Alicia Evans. I'm joined here today by Dr. Josh Shaw. He's a transplant surgeon and HPB surgical oncologist at Broward Health.
Great. Thank you very much for having me.
Hi, Dr. Shaw. I'm happy to have you here. Welcome to the show. I'm excited about our conversation. You were able to provide some really interesting insights into pancreatic and liver cancer and what that looks like from a surgical perspective.
Yeah.
Exciting. Go ahead.
No, sorry.
That's okay. So Dr. Shaw, if you could just give us some information before we jump in, a little bit about your background and what you do.
Sure. So as you said, I'm a abdominal transplant surgeon. I focus primarily right now on liver and kidney transplant and living donation. On the oncology side of what I do, I deal primarily with liver cancers, biliary cancers of the gallbladder and the bile ducts, and then cancers of the pancreas as well.
Okay, so all abdominal. And so what brought you into oncology? What inspired you to?
Yeah, oncology is an incredible field. It's always evolving, and it's one of the few fields similar to transplant that really has a multidisciplinary approach. So it's not surgery is the end all be all, but it is truly a team approach with every other specialist who deals in oncology, whether it's medical oncology, radiation oncology, and all of the ancillary and support teams that we have working together to come up with what is the very best way to treat this patient. And sometimes that includes surgery, and other times, importantly, it doesn't include surgery. So, I think it's important to know the difference of when to do which. And, it's like I said, it's rare to see that in most surgical specialties, a field that works as closely with our medical colleagues as we do in surgical oncology and transplant for that matter as well.
So you're all working as a team for the patient's, of course, about well-being. So often there's like a handoff, right? So you go from one specialty, medical oncology, to surgical. And so patients, they're doing that handoff. What are some ways from like a medical oncologist's perspective, handing it off to you, that we can help patients kind of hit the ground running, right? And prevent any delays in treatment?
Sure. So I think one of the biggest problems we see in surgical oncology is patients are often referred to a surgical oncologist for evaluation of, for in the example of pancreatic cancer is, they'll come and see me and they'll have a report or a read of their CT scan, but I need to see the actual images, and usually that delays everything an entire visit. So for instance, when you go to see your surgical oncologist, no matter where you had your CT scan or PET scan or whatever the imaging you have available, you want that on a disc and you want that in the hands of your surgeon, because they look at it in a very different way than, say, a radiologist would. We're looking at it, in the sense of, is this resectable, but where would our margins be, and information like that you don't always get from a report. So I think that's one way. And then the other is actually making sure they're coming with the right scans, is the right protocoled imaging. So, for pancreatic cancer, by the NCCN, the National Comprehensive Care Network, has guidelines of what are best practices for a pancreas CT, the phases of it and the thickness or the slices in which they cut that CT. So each time you click the button, you're only moving about 0.5 millimeters at a time, versus a normal CT scan is anywhere in the neighborhood of 3 to 5 millimeters. So that's also really important to make sure you don't just have the imaging with you, but you get the right imaging done.
Got it. So to kind of arm our patients and to help them have the best experience when they have that consultation with you, we need to, of course, examine the NCCN guidelines. and then make sure we have our patients have the actual, not a report, but a disc of the images.
Correct. Yeah. And I think when patients come and see me, that's all they want to know to start. It's can you take this out? That's question number one. And then the how, the when and the where, all that follows. But if I can't answer question number one, everything else becomes a hypothetical question of if this is good, we'll do this, this, and this. And it leaves a lot of uncertainty, which, obviously in pancreatic cancer is a very aggressive cancer that has, unfortunately, a very high mortality rate associated with it. And it causes a lot of anxiety in people, and coming to see someone and not being able to tell them what the next steps are definitively, I think is really challenging.
Exactly. So without these, we're looking at probably possibly extending the time to treatment, right? A weeks, months, possibly, right? Depending on when the patient can come in again.
Absolutely. Yeah.
Okay. So, again, on patient treatment, last time we talked about operability and how that what is considered operable has changed so much for pancreatic and liver cancers. Can you tell us a little bit more about these changes or these developments?
Sure. So I'd say the definition of operability has really evolved more so in the setting of pancreatic cancer than liver cancer. But in pancreatic cancer, historically, there were certain elements of pancreatic cancer that if certain vessels were involved, and to a certain extent how much involvement there was, would be what you would call a hard stop for a case, meaning you would not go forward with doing that operation. It was considered futile, and it was considered that there was no survival benefit to doing something, which is, from a surgical oncology standpoint, that's one of the driving factors behind every decision we make. Is if there's no survival benefit, if a patient doesn't get a significant advancement or prolongation of their life at a high quality, does it make sense to do something? And historically, if certain vessels were involved, people would say this is not an operable pancreatic cancer, and almost certainly condemning them to death. And what has happened over the years, and in part it was done more on the international scene, as people began resecting cancers or pancreatic cancer that people thought were not resectable, and have actually shown very similar outcomes to the other patients who had resectable cancers, that aren't that different. And the Canadians, the UK, the Europeans have shown that fairly definitively at this point. And in the United States, we've evolved here as far as what our practice patterns are of what we consider resectable now. So there are, and to be fair, if your medical oncologist has never had a surgeon who takes these patients on, they may not know that, and be doing practices that are considered older, which is unfortunately a disservice to those patients, that they may have something that is in fact resectable, that, again, someone practicing 20 years ago would say is not resectable, and back then that was the right answer. But today it's changed a little bit, and that's one of the things we've seen. When I was in training, you'd say the 5-year survival from pancreatic cancer, all comers, was in the 20% neighborhood. Now it's about 30%, and you look at the medications and the regimens we're using, there's not a ton of difference. What I believe is different today than 20 years ago is we're being much more aggressive with who we take to the operating room. And again, you see that improved, overall survival. Again, it doesn't benefit everybody, but you have an overall improvement in survival, which I believe is related to that.
Absolutely. So are you saying, is this something that's happened in the last 10 years, the last 5 years? Are we looking further back?
Yeah, to be honest, it's really institution specific. You have places in this country that are huge cancer centers that are very set in their ways. of how they do things, and have adopted new practices very openly. But you also have smaller centers that have been, for lack of better words, boutique type places that do these operations. And as a result of that, they don't evolve. They've been practicing the same way. It may be one or two surgeons there that do those operations. And, if you weren't trained to do it, you're not going to do it. Unless someone has actually shown you how. And I can tell you there are a number of HPV surgeons who deal with pancreatic cancer who are very uncomfortable doing vascular resections.
Okay. So how do you know if a surgeon has received that training?
I would ask them.
Just ask.
I think I'd start with that. And, the other things they've shown in pancreatic cancer, and it's challenging because if you do more than 15 of these operations a year, you're considered a high volume center, not just a high volume surgeon, but a high volume center. So there are surgeons who are doing less than that. They may do 5 whip. A Whipple is the name of the operation, which takes the head of the pancreas, or you can do what's called a distal pancreatectomy. You take the tail. I always tell patients, think of the pancreas like a fish. It's got a head, body, and tail. Mm-hmm. And, about 70% of the cancers are in the head. The other 30, give or take, are in the tail. If you do about 15 of these a year, you're considered a high volume center. So if you have 2 surgeons at that center and each of them are doing about 7, give or take, that's not a lot. And again, you have some very high volume centers that do about 100 plus of these a year. So I think that's important as far as where you go. Those are things as a patient I would want to know, is not just how many the individual surgeon does, but how many they do at that center. They've shown in the literature, the high volume centers actually have significantly improved outcomes. And it's, as much as, as a surgeon, I always wanted to believe those things were because of me, but it's actually the nursing. They have, the nurses are able to recognize when problems are happening, they respond more quickly, or they have fewer episodes or events where, quote unquote, failure to respond, where something happens and people just let it go because they don't realize it's a harbinger of something even worse about to happen. So that's one of the things you'll as a patient or as a family member certainly want to know, is how much that individual surgeon does and how much or how many of these operations that center does. And if it's less than 15 or 20, I would be very careful about having it done at wherever that is. And it's not to say those surgeons and centers may not have excellent or be excellent at what they do, but by the numbers alone, those are concerning features.
That makes sense. The more cases you see, the more experience you have, and the better you get. You develop your own best practices.
Absolutely.
And so COVID-19 has changed so much, right? And so many of us have had to adjust the way we practice. We've had to move to telemedicine. We can't have as many support staff, or rather family as support for our patients in the office as we used to. What are the ways that the recent pandemic has affected your practice? I know you can't do virtual surgery, but yeah. How has it changed your work life?
Yeah, so the pandemic has really changed the face of medicine. And in South Florida, there was a period of time here where it was really bad, where the hospitals were flooded with COVID patients. And as a result of that, other patients did not want to come into the hospital. And, I saw in my practice patients coming in with biopsy proven or highly suspicious CT scans suggestive of pancreatic or liver cancer that were coming to see me later and later. Normally, when someone gets diagnosed with something like this, you see them, they're calling you as they leave, the emergency room or their gastroenterologist. Yeah, they want that out. And, for the first time in my practice, I was watching patients come in who were getting diagnosed 3 to 6 months prior, which when you think of the median survival of some of these cancers, it is 3 to 6 months. So when they're coming in having waited that long, it's you are so far behind the 8 ball at that point. It's incredible. And, patients were more afraid of COVID than, quite literally a terminal disease process for almost everybody who gets it, compared to, COVID, which in COVID's a very serious and potentially lethal problem for many people, but it's still a minority of the people who actually get it. The vast majority are totally, fine compared to, I can't say the same about pancreatic cancer or liver cancer. And so it was really a shock to watch patients coming in that were so delayed. And then, with oncology, where you have this multidisciplinary approach, it's true across the board. So instead of someone seeing me a day or a week after they see their medical oncologist, it's everything gets backed up further and further. Which again, usually the surgeon is one of the, not the last, but one of the last people you see, usually in that pathway, getting worked up for a cancer. So it was shocking, honestly. I think there was a lot of delayed care for a number of people. Fortunately, that is subsiding in South Florida. I can't speak to the rest of the country, but I'm sure other healthcare professionals and other surgeons who deal with what I deal with saw very similar things. And there's an untold number of deaths that I'm sure have happened because of that. I mean, I can think of all the people who stopped getting screening colonoscopies, and for every 100 colonoscopies someone does, they find a cancer. If all of a sudden you're not doing them anymore, it doesn't mean colon cancer just stops. Those things are still happening. So there's an untold number of people who were really adversely affected by COVID without maybe even getting COVID itself, but because of the environment it created.
Those delays in treatment and another delay and another delay.
Yeah.
So what do you so our patients who are hesitant about taking the next steps in their treatment because of coronavirus, they don't want, of course, no one would want to be sick, but what do you suggest that we say to them? If they say, oh, well, I don't want to go in for surgery, I don't want to expose myself to coronavirus. What should we say to them?
So I would start by saying they should be vaccinated. I think that's important, and that actually goes for family members as well that are going to be dealing with a critically ill or potentially critically ill person who's maybe had surgery or as a result of chemotherapy or radiation is immunocompromised. I would start with that alone of get vaccinated so that fear can subside. And I would encourage them not to wait. That pancreatic cancer has a much higher mortality rate than COVID. And waiting it's like waiting with a ticking time bomb inside of you, and you need enough time on the clock to fix it. If you wait long enough, it goes off, and when it goes off, it's you can't put it back together at that point.
Exactly. Thank you for that. Maybe some phrases there that we can use, pass on to our patients to help encourage them to continue and to kind of speed up their processes. So are there any other adjustments that you've had to make because of coronavirus?
Yeah, one of the things I have done is when we actually get referrals for patients with a new diagnosis of cancer, one of the things I've done is I call the patients and to, encourage them to come in and be seen, and things that truthfully are not pleasant phone conversations to have with people, but I think is necessary in order to get them to want to hear it. Because sometimes that's another piece that often happens is people will come into a medical oncologist office, a gastroenterologist, a radiation oncologist, or a radiologist, interventional radiology, and they may have a biopsy done. And a lot of times people come and see me and they haven't actually had their results from their biopsy told to them.
Oh.
And these are things that are usually, patient portals or a my chart or any of these kind of electronic versions of our medical record that patients can access. Some centers will withhold these from being published there, because if someone pulls it up and they see a new cancer diagnosis that no one told them about, you can imagine that that generates a lot of phone calls, a lot of anxiety. So there are some systems that will withhold that until the ordering physician releases it. So a lot of times, someone may biopsy something and the patient has no idea what was found there. And, again, those are not conversations meant to be had over a telephone or, but in the age of COVID, when people are, very hesitant to come in because they don't even know they have a serious problem yet, that becomes, something that I've adopted, where I will call people and let them know that not necessarily what their pathology shows, but that they need to be seen and, to go over what was found on their biopsy or whatever the procedure was, if there were concerning findings during a CT scan, and have found that patients are fairly responsive to that when someone actually reaches out and talks with them about those things. Those are the big things. The other things from a surgical standpoint is any of our patients coming in for elective operations, they're all getting tested for COVID beforehand. And, if someone tests positive, they're not disqualified from getting surgery, but other precautions are put into place as far as what operating rooms they go into and what part of the hospital they go into. So fortunate, Broward is a very large hospital system, and we had very specific parts of our operating rooms and our hospital itself that were designated specifically for patients with COVID, to keep patients who didn't have COVID, separated from each other, but also being able to provide the same level of care for both sets or both cohorts of patients.
Exactly. Sounds like there's a lot of changes that
Yeah.
you've had to adjustment. You mentioned earlier vaccines. If you have a patient who is coming in, do you encourage them? You encourage them to get vaccinated, but is it a requirement or?
Yeah, no, it's certainly not a requirement. I think, it is a lot easier knowing someone has had a vaccine in the sense that a lot of things, and I've seen vascular surgeons talk about this, that you see there are certain, I don't want to say phenomenon, but there's a lot about COVID we don't know. So people who get it, are they more hypercoagulable, or do they have certain other concomitant problems that we just, because it's so new, we don't realize it yet. So I think knowing that patients are vaccinated, you can take a lot of those things off the board.
One more factor that you don't have to consider.
And I can tell you, I can think of a number of patients that when they start to do something that, again, whether it's part of the course or not, when they start to get unusual findings or something that, I've heard a lot of people say, oh, it's probably COVID. And there's not a lot of peer-reviewed literature or evidence to support that. But at the same time, we have these findings that are unusual that we can't explain. And we have a new virus out there that we also, we understand somewhat, but we don't know a lot of the long-term effects and things like that. So I think it's, again, it's not mandatory. It's certainly, I think from my end, makes things a bit easier. But it's not mandatory. But I think from a population health standpoint, it's important to be vaccinated.
Absolutely. And the vaccination numbers are climbing. So more and more of your patients will be coming to you already vaccinated.
Yeah.
Oncology is such a stressful field. You are dealing with extremely ill patients. How do you manage your stress?
Oh, so oncology is not stressful when you compare it to transplant. So transplant's very stressful. Oncology for me is very relaxing. But no, I personally enjoy it very much. I actually don't find it particularly stressful. I truly love what I do. So are there stressful situations? There are, and I find dealing with them head on, the most common stressful situations usually come under the cloud of communication with patients and families. And there's a lot of anxiety and fear that go along with a cancer diagnosis like pancreatic cancer, where, if you Google pancreatic cancer, you don't see a lot of good things. when people Google the surgical procedures that I perform, they have a high morbidity and mortality associated with them. And that scares people. And that for my patients is an incredibly stressful event. I view my job as to educate them. And I think with education comes a certain, it helps to subside some of that anxiety, certainly not all of it. And I think all patients are somewhat different, but for me personally, I don't get that stressed out, and that's probably for the better, or for the best of my patients.
Absolutely. If you can keep your calm and keep your cool, you can communicate and share that calm with your patients. They must be very grateful to have such a calm, cool, collected surgeon.
Yeah, I was told in my training years that when everyone else loses it, that's the most important time for you to stay cool. People will often look, and whether it's in the operating room or the clinic or the inpatient setting, they look to their physicians, whether it's a surgeon or not, but to set the tone. And if you're stressed out or you're running around, it transfers to the patients, it transfers to the nurses, the rest of the team. And, ultimately, I think those things lead to potentially worse outcomes and worse experience for patients and their families. And, as anyone who's gone through it, a cancer diagnosis, no matter how the outcome is a stressful period of time in their life. So I think it's important that, they're at a place where they're comfortable, and, the team there does not add to that stress. If anything, helps to correct it.
Excellent. Thank you for that advice. This has been a really great conversation. For any of our listeners who want to reach out, with follow-up questions, what's the best way for them to do that?
So can I leave my email
Sure.
within the...
I can add it to the show notes. Will that work?
That would be perfect. So
Excellent.
My email is j1shaw@browardhealth.org. But if you can add it into the notes, and I'm happy to respond to emails. If you type in, South Florida Transplant Center or South Florida Transplant HPB Surgical Oncology Center, our group should pop up. But I'm more than happy to respond to emails directly with any patients, families, or just independent folks out there who have some questions about pancreatic cancer, neuroendocrine tumors of the pancreas, liver cancer, liver transplant, pancreas transplant, all those things. I'd be more than happy to discuss with any of your viewers.
Oh, that's very generous. Thank you so much. Yeah. Our audience will surely be grateful for that. And I thank you for being a guest on the show. Thank
you for having me. This is great. I think it's great what you do, and it's important to get, this type of education out there into the world.
Thank you so much.
You've been listening to Working in Oncology. To ensure that you never miss an episode, subscribe to the show in your favorite podcast player. If you're listening in Apple Podcasts, we'd love for you to leave a quick rating of the show. Just tap the number of stars you think the podcast deserves. Thank you so much for listening. Until next time.